So can we have our panel members? Can we have our panel members up here for our first session? Vibhav Narayan from Janssen, Peter Poemans from IMEC. To come up. Mila Kivipelto, Professor of Neurobiology at Karolinska, Kim Barton-Christensen of Brain Plus, Margaret Walker of UFAMI, and Katerina Polychronopoulos from the University of Vienna. I'm going to take you from that seat and put you in. I told you we had a cast of thousands. Okay, so each of you are going to introduce yourselves. You're going to have strictly just 2 minutes to introduce yourself and brain prevention and health from your point of view. So let's go with you first.
So my name is Peter Poemans. I'm from an organization called IMEC here in Belgium. What we, for the past 35 years, we've helped large industries advance technologies that all of us use in our smartphones, in our computers. And some of these tools might be used actually to generate digital biomarkers. But what we're interested in now is in leveraging these very powerful platforms, not to build better computers, better cameras, but to build tools for the life sciences that allow you to peel away layers of biology. And recently we've partnered with the local university, Catholic University of Leuven, the researchers over there, and the local university hospital, the clinicians, to understand how in dementia we can specifically develop technologies that allow you a much deeper insight into the biology, and that would also allow you to develop tools that in the clinic would really make a difference in terms of care for the patient.
Okay, thank you very much.
So thank you. My name is Mia Kivipelto. I'm professor in clinical geriatrics at Karolinska Institute. I'm also the director of research and development at the Theme Aging Karolinska University Hospital. And I'm really happy to be here today. Brain health and prevention, I really think, is the key. And as an example, dementia and Alzheimer's disease, we know that the process leading to dementia may start 20 to 30 years before we can do the diagnosis. So there is a wonderful window of I would say, opportunity for these different type of interventions. So timing is important. Probably it's never too early to really start to prevent dementia. The second thing what I would like to highlight is what we have learned from our epidemiological and clinical studies. Dementia and Alzheimer's disease are very complex, multifactorial, heterogeneous conditions. So one size may not fit all. We need to have multi-domain interventions. We need to target several risk factors and mechanisms at the same time. At the same time, we should have more tailored interventions, writing to find the individual risk profiles, and here I really think the new technology may help. Finally, I would like to highlight the new findings we have from the FINGER trial. FINGER was the first large multi-domain randomized controlled trial, really showing that with the multi-domain intervention, with physical activity, cognitive training, diet, social activities, taking care of all vascular risk factors, you can reduce the risk of both cognitive and functional decline. Now the interest is so great for the brain health, we have established the worldwide FINGERs, and there are more than 20 countries globally joining that initiative. So this is the challenge what I would like to say. What can we do jointly? What is the FINGER 2.0? What is the new generation of trials? How we can use technology to really make the next step? And I would really like to hear more about this.
Okay, thank you. Vibhav.
Thank you. So my name is Vibhav Narayan. I'm Vice President in Data Sciences at Janssen, which is the pharmaceutical wing of Johnson & Johnson, which in itself is the world's largest healthcare company. And although I do work in pharma, we as a broadly based healthcare company do think about prevention and health quite a bit as well. And there are many points that will be made today. I want to make one point. And I want us to think about what is it that we can already do today for brain health. With the high-level mantra, first, do no harm, everything has to be evidence-based. However, we already know certain things are good for your brain health. sleeping better, being socially engaged, being physically active. And you know what? All of these things can now be measured passively and quantified. One of the key things that motivates people is measurement and a number, right? Look at cholesterol. People work very hard to lower their cholesterol even though they don't feel it, because they know that there is a number I can lower, and lowering it reduces the risk of cardiovascular disease. Can we create a similar number for brain health that does no harm, that people can engage with, that's even more modifiable than cholesterol? By maximizing that number, you improve your cognitive reserve. You build more resilience to cognitive decline. You may not prevent disease, but you can build resilience. And can the data for this number be passively collected and automatically calculated? It will be personalized. It doesn't matter what your absolute number is. What matters is, are you bringing it down? Are you improving it? These are the things that I think we should think about. What can we do today to measure brain health, track brain health? For the average person, brain health is a black box. And a lot of the research that's going on, and Mia talked about it, we are already identifying. And this evidence base will grow. We will know more and more about what factors are important in brain health, but I think we already know enough to really start tracking and measuring some of these and engaging people in what I call a brain healthy lifestyle. And I'd make one last point, that what's good for your brain is also good for your heart. And really, if we do a good job of this, it will have widespread benefits. We do have some thinking about this in our company. We want to collaborate with others to sort of really push for a brain health number. And we'd be happy to sort of discuss more and talk with others as the day wears on.
Okay, thank you very much. Kim.
Hello, everybody. My name is Kim Baden-Christensen. I am the CEO and co-founder of Brain Plus. Brain Plus is a European digital therapeutics company based out of Copenhagen, and our mission is to increase global brain health and very boldly to find a digital cure to brain disease. And by that, I mean to treat, to detect, and also to prevent, because some things we can't cure, at least not today. And so the prevention effort becomes very important. The way we work with that is on mobile apps to engage people directly, and a global platform for clinicians, where we combine cognitive neurostimulation exercises with behavioral therapy. So we are combining some of the things that you know perhaps from Achilles' model, some of the things that you've seen from a pair model, into one platform. We're working with numerous stakeholders. We don't believe we can do this alone. I like very much the point on diversity and the necessity to work together. We have a couple of European projects where we work with, one is in early detection and prevention in Alzheimer's disease, for example, where we work with the European Brain Council, with the Alzheimer's Europe patient organization. So we believe very much that we need to work together to both find the right solutions, but also to cut the pathway through the jungle. I think one of the things that we're challenged with in Europe very, very much here is this fragmentation that we have. We need to be more mature. We need to mature ourselves from both a regulatory perspective, but very much from a mindset perspective when it comes to digital health solutions and digital therapeutics. And that could be one of the very good things that IMI could help with, I think. Thank you.
Thank you.
Good morning. My name is Margaret Walker, and I am the Executive Director of EUFAMI. EUFAMI is a European federation which groups together 35 member associations in 22 countries. Our main focus is to work with families who are affected by mental ill health, and more specifically, we work in schizophrenia, bipolar disorder, and major depression. It's fantastic to be sitting here and to be discussing this specific topic of prevention and how we can perhaps use digital technologies to help us with this. EUFAMI is placed, has a position whereby obviously our parents and the siblings are looking after patients or service users, people affected by a mental health condition. But at the same time, they themselves are at higher risk of suffering, for example, of depression due to the burden of caring. So I think in particular looking perhaps at how we can help them understand that this might happen and how we can perhaps use digital technology to help them manage the possibility of major depression, or when they have depression, of actually being able to manage the symptoms, being able to better cope, and perhaps build some resilience. So, and I think one of the things I would like to mention as well is UFAMI is involved in the PRISM project, which is an IMI project, something that we have found very interesting and very useful. But I would like to mention the importance of, when engaging with stakeholders such as patient groups or family carers, to understand the importance of using a language that we can ourselves understand. I must say some of the terms used this morning, very impressive, but they went way over my head in some cases, and I know that this would be the case certainly with our members. So while at the time we're talking about engaging with all stakeholders, we have to bring perhaps some of the language that we use to a level that we can all understand and relate to. Thank you.
Thank you. Katerina.
Good morning. My name is Katerina Polychronopoulos. I'm an American lawyer. I work as a research associate for the Center for Digitalization and Innovation in Law at the University of Vienna. We work on a lot of EU-funded projects and some IMI projects dealing with basically advising from a legal perspective medical partners, research institutions, and universities.
Thank you. I want to touch on a point that Margaret came up with, which is about digital inclusion. Because at the moment we see a huge take-up of devices by people who are already probably quite healthy and wanting to be healthier. But actually the great burden of disease is in people who are often may not have that much access to digital devices or indeed to healthcare. How are we going to ensure that if we do take up this, take this direction, that we are going to ensure digital inclusion?
I think one of the challenges is that with some of the conditions that we're talking about, and I'm thinking of Alzheimer's, of schizophrenia, and major depression, there is a risk that patients or service users might not wish to use the technology at a certain time. And I think one way in which we can overcome this, if perhaps the family is more involved, the carers are more involved, because they're able to step in and perhaps provide some of the information when it's needed through the digital technology. The other thing we can do is perhaps explain better and simplify how the technology can be used, make it more easily accessible, and for that we really need to involve patients or service users directly from the very beginning in the actual planning of the digital technology and how we mean to use it.
And have it be frictionless, I presume, where perhaps you're not aware that you're wearing it, although that,
Yes.
of course, carries its own problems.
I just do want to add to this, because I know that the whole concept of digital divide is a real one. But in fact, we can also look at this as an opportunity. I think digital means is going to democratize healthcare in ways that's not been possible before. People will have more access to digital devices than they will have to psychiatrists and healthcare systems. Almost everybody will have a smartphone. That's the direction things are going in. And to your point, if the data collection is frictionless and passive, and smart algorithms generate insight from these data without creating any burden on the individuals themselves, then this, I think, leads to better healthcare for more people. So I think digital will help bridge the divide, in fact.
And of course, but that also carries its own regulatory problems, because, for instance, with schizophrenia, we know that when people are beginning to become unwell again and they lose insight into their condition, and then they just abandon everything that they normally would do. And at that time, that's the moment that you'd want to get them in care. But a lot of countries, they will section at a later stage rather than that earlier stage. So that's a very difficult, and the patient has to be involved in that. So that's a very difficult thing. We need to think about reorganizing how we do that.
Yes. I totally agree, and again, I see new technology as an opportunity. If we take dementia again as an example, and we are thinking low middle-income countries, actually these are the countries where we have the largest increase. Mobile phones are increasingly used globally, so there are a lot of opportunities. I also think that the new technology can really help in self-management, monitoring, what we can't do in the clinic. It can also lower the, kind of threshold to come to the clinic, because it is still kind of stigma if you start to feel cognitive impairment. Maybe doing some risk scores or some tests online may be easier. But I agree, there are a lot of regulatory aspects what we need to do. For example, before we start the new global initiative, so these need to be there. And we as researchers, we do not always have that knowledge. So we just had a lovely discussion that we need to work jointly with different stakeholders to make it happen.
We've got a question through from Slido, which is a great question about people diagnosing themselves. There is a big danger. I mean, people pitch up to their GPs with Dr. Google results, and they've completely misdiagnosed themselves. How do we stop people doing that?
Well, the simple answer is if you have let's say a digital therapeutic like our own, as soon as you get people onto that platform, you tell them, go see your GP if you think you have any issues. It's very simple. We should include the clinical community in everything we do in digital as well, and make sure that there is a tight connection between the two.
Okay. And I would just add that there are, as you say, there is a need for evidence-based tools. So again, here the research is needed. There are so many apps and tools out there, so evidence-based is important.
How about voice detection? Because again, that's a question that's come up from Slido, because voice detection is so much better now. What are your thoughts on that?
Well, I wanted to add in the context of the digital divide, that also our environments are becoming a lot smarter. It's not just the smartphones that will be collecting data, but also the rooms we're in, the buildings we're in. So if we can just agree on and also localization is getting better, so you know which person the data is coming from. So if we can all agree on how data should be shared and data privacy rules, there's a lot more than the smartphone, and that would solve to some extent digital divide.
Okay,
and it also applies.
Let me ask this audience: how many of you would not welcome a future in which this room had could collect your speech patterns? Yeah, there are quite a lot of you. Going down to your local bar, would you be happy that there were? So there are lots and lots of concerns here from the public.
Yeah. My microphone's not on apparently. Okay, there we go. I think from a regulatory perspective, the GDPR would make that quite difficult to do, just mass collection of data. Would be considered personal data if it can be connected to a natural person. So.
I think this brings up the question of motivation, and that also goes back to inclusion. It's not the availability of the devices. We have the technology, but we need to get people motivated to actually both accept the technology, be willing to share it, and more importantly, if we're talking about prevention and treatment, we have to motivate them to actually act. Alzheimer's disease is another great example of a lot of people who either have the disease or they know their family member have the disease, but they're not willing to share that with anybody. It's stigmatized. How do we actually motivate them to act? So that's one of the key inclusion criteria, I would say, inclusion aspects we need to work with.
So these things have to go hand in hand. So you have to have the social science involvement. Detection is not enough. Right. You need to know, what are you going to do with it at the end?
Yeah, I do want to make the point that I think we all have a responsibility in how we frame this, right? If you ask the question, are we comfortable with this room collecting our speech, the answer is most likely no, right? The reality is we are all emitting light right now, and all sorts of cameras are capturing our image, right? And this has happened all the time. I think the real question is that every individual should have control over how their data are used and how they are analyzed, right? And then if you ask the question differently, would it be okay if we use your own speech data that you own to detect signs of early disease such that you can prevent it and we can give you an early warning, right? it's a very different question. And there will have to be a lot of education around this. We are not listening to what you're saying. Maybe the analysis, and and IMEC will help with this, all happens in situ, on your phone, right? The only signal that ever leaves is a risk signal. And the only person who ever receives it is the person you already designated. Maybe your primary care physician, maybe your loved one, and maybe nobody. So I do think that this is going to be about very helpful reuse of the data that you generate anyway. Reuse is a good thing, right? In the context of your own health and in context of how you decide it should be used. So I think we have to come a long way. We collectively have to come a long way on how these questions are framed and how we handle these issues.
One particular problem, of course, is going to be how we ensure the reliability of these kind of devices. Because, you can get all sorts of stuff on Amazon as it is now. What's good and what's not. How are the public to know what's a good device that does what it says on the tin and those that are not?
I think that this issue was raised in the talk, Professor Spani's talk. I do think this is a massive issue. I think this is an issue that will not only harm people, but also limits investment, right? If you can have 4,000 apps on the Google store all making claims that are not true, then why should any responsible entity invest more money in developing something that is true? Because it will be just drowned out. And I think at the end of the day, we have to make sure that whatever we are doing is evidence-based, where performance is clearly articulated in a transparent way. And we have to just be truthful about this, right? If I sign on to a service that I hereby allow these data streams to detect signs of cognitive decline, or I want to participate in a brain health score, I want my brain health score to be calculated on a monthly basis, daily basis, and I want to improve it, then I should know what really is the value of that score, what is that score really doing, and it doesn't have to be perfect. These will be learning algorithms. They will get smarter and smarter as we collect more and more long-term data, as more outcomes are associated. But we have to separate those that are data-driven and evidence-based from those that are just apps, just pieces of software that are out there.
Yeah, and just a short addition, I totally agree, it's the communication. You mentioned that how we are communicating, what is it that you have increased risk? What does it mean? If you are a young person, if you are at midlife, if you are 80, it's a different thing. Life course risk, what you are having. And also, if we can give some feedback, you are not only having increased risk, but you can do something for that. You can increase your brain health, and again, that comes back for these lifestyle interventions, what we have, starting to implement it. We know that it takes 15 to 17 years to start to implement research findings. I think it's absolutely too long time. We don't have so much time. So can we use new technology to implement these healthy lifestyle things to increase brain health? I think that would have a huge impact.
And the worry is actually that if we, delay rollout because we're so concerned about standards and regulations and all the rest of it, although that's critically important, what we allow is the void to be filled in the meantime by a lot of stuff that actually doesn't have any value and which may permanently damage the image of digital health.
Yeah, I think, oh, sorry, was there a question?
He's trying.
So our agent provocateur is in the audience.
Mike would. Oh no, it does. So I just sorry to block you here at this point, but I was just about to make this one point, or want you to consider one point. You talk about the evidence base and the evidence base that you should refer to if you see your practitioner or so. This evidence base comes from the pre-digital era. Yes. And I see a major issue with the interpretation capabilities of specialists and general practitioners when it comes to digital signatures. Even those people producing digital signatures are not able to relate them to, for instance, progression models that we have on the biomarker side of things. This is something we address in the RADAR ID currently, but it's difficult. It's really, really challenging. So the question is really, how do you want to relate the old world with the new readouts?
So I do have one plea for anybody who has control over this. We want to do this in pharma, others should do it as well. Please, please try and include digital measures in your traditional studies, where you're also collecting other biochemical data, other biomarker data, other clinical data. I think over the long run, the only way to sort of make progress in this area would be to not treat digital biomarkers as a standalone thing that is devoid from correlations with other clinical readouts and molecular readouts and imaging readouts. And these types of hybrid studies, we should really encourage and longitudinally follow.
Yes. So is that a suggestion for IMI, Viva?
It's a suggestion for anybody who is doing clinical studies where they can include digital measures.
And if I may add, so this is exactly what we would like to do, for example, with the worldwide fingers. I mentioned the 20 countries from different areas. Why not to include more digital biomarkers, having the traditional ones, and that would be a beautiful data and increase the evidence base. So I think this is a great opportunity for that.
Okay, we've got some more questions from Slido, and the inevitable one here, amazing digital innovation coming, but who's going to pay for the rollout in practice? Public health doesn't have much money. How can we, and it goes back to our previous question, we avoid increasing the divide between rich and poor?
Well, I'll give that one a shot. I think the traditional payers should pay part of it, and we need to get to a point where digital solutions are reimbursed on the same in the same way that current medicinal solutions or other solutions are today in the healthcare system. For that, we require evidence, of course. So how do we create that? We need to find a way where we can de-risk that evidence generation until we've created at least a clear pathway all the way from having an idea and concept to having that tested, clinically validated, regulated, and so forth, and having clear guidelines for what that looks like, because that will make it much easier for payers to accept. However, right now we need to have some payers. We need to have the public health systems. We need to have the private companies all chip in and take a step towards this. So that could be an IMI project, could be how do we take an idea from idea stage concept to a digital solution, to clinical validation, to regulatory approval, all the way to reimbursement in a number of, let's say, European countries. And how do we manage to make that entire pathway as smooth, as clear as possible, because that would truly accelerate things. And how do we de-risk that pathway for the different players?
And can I add something else onto the end of that, is that you need to find a way to include this information in the electronic health record. Because at the moment, if any of you go along to your doctors and say, here's what 23andMe told me, or here's what my digital device tells me, what your GP will do, first of all, is say you don't want to believe what people like that tell you. And then the next thing they'll do is they'll say, there's nowhere for me to do this, and they'll probably scribble it on a bit of paper. Yeah. So that's a real issue, that this has to be right through to the patient contact at the other end.
I think that I'll just say this, that this is an important point, and builds on the previous point that was made. Digital biomarkers by themselves may have the sensitivity, but they will never have the specificity if they are not combined with clinical information. So you will have to figure out a way how to integrate clinical information, clinical diagnosis with the digital data to really make progress. But I do want to come back to this payer issue, because what I don't want us to do is to throw away the real advantages of digital technologies, which is that they are scalable at a very low incremental cost. So if we keep thinking about the traditional ways of reimbursing them, I think we would have missed an opportunity here. What we mean by reimbursement is that if a physician is spending time looking at output of a digital sort of diagnostic that a patient brings to them or it gets communicated to them, the physician has to be compensated for that time, right? And that could be done in traditional ways. But how the system actually pays for the digital diagnostic or the digital therapeutic as it gets on people's phones and as it sort of generates insights, we have to think about novel business models here, okay? It won't just be expecting the government to reimburse you for that app on your phone. We can deploy apps at low incremental cost. What's the business model? Who generates the value? Who captures the value? How does value accrue to different stakeholders? This is something that we, in companies like ours, think about all the time. And without proper business models, and business model here is not a dirty word, it will be hard to really make progress in this area.
And also, Vibhav, you want to make sure that the data that comes back from apps is not proprietary. In other words, if you really want to make a difference, that you combine those data sets. Because otherwise what happens is people want to clutch data to themselves all the time, and you don't get the benefit of those zettabytes of data.
So ideally, data from individuals should be pooled, de-identified, so that algorithms can train on it and get smarter. But your own data should be used to make prediction only on yourself. So it's a hybrid model of control over how your data are used, but as a citizen scientist, I contribute my data to a larger de-identified pool, and algorithms continuously get smarter. Yeah.
But when they go through to the, let's say, Janssen or Johnson & Johnson has an app, that the data doesn't just accrue to individual companies.
It's a slightly more complicated question. I think different entities can use that data set to train their algorithms, right? But if any entity has developed a system, then should they should be able to train their algorithm on their data set. I think that ideally these data should be shared, but there are many ways in which you can keep the data sort of asset as an asset and let people train their models on it, and this has been worked out in other settings, and it can be worked out here as well.
Okay, Katerina, I want to come to you because somebody on Slido has asked about the problems where you have cross-generational, and they were talking, I think, about Huntington's in particular. How do we address the problems of data regulation when there's a cross-generational involvement?
Yeah, I saw that. That's a really good question, and we've actually faced that in a couple of the EU projects that we've been doing. So the question first, it's important to distinguish between whether you're dealing with aggregated data or with personal data. So if it's aggregated data and it's anonymous, then you don't really need to worry about it because the GDPR doesn't apply. If you're dealing with genetic data or data that can be traced to a natural person, that's a completely different question. And there is where, as Luca was saying, the GDPR gets kind of tricky and yes, can tend to stifle innovation in terms of the fact that there's a lot of confusion over what the GDPR requires, when it applies, and how we comply with it. So there are a number of opening clauses. There's a clause which explicitly allows an exception for scientific research. So you don't need to get patient consent if you're doing scientific research. But the opening clause says, according to member state law. So different European member countries are free to basically implement the GDPR in the way that they choose for that. So that's still quite an open question. The short answer is, if you don't have a consent that you can go back to, you need to look at national law to determine whether you can reuse or reprocess that data. And you also need to look at the clinical trial regulation, which is going to come into force in 2020. That has a little bit more of a flexibility in terms of reuse of clinical data, but is also pretty stringent in terms of requiring consent.
Okay, you had a point.
I just started to think of that it is really, we have a unique possibility, I would say, here in our countries and in Europe, but we also have these, I would say, challenges. And again, if I come back as a scientist and where we are, so this support is so important that when we start planning, for example, the finger trials in different countries, using online brain register to find the individuals, using different apps, what we need to do that we can really optimize the opportunity what we have, not losing this big data because of some things we have not been doing. So I would really like to welcome more kind of collaborator or joint efforts to make it happen. I really think if I'm thinking European participants, the willingness is there for brain health for different ages. So we have all the opportunities for that.
What do you all feel about the question of whether we should only be looking for things for which there is an action that can be taken? Because there's plenty of things that you could find with these kind of technologies for which there is no current answer. And might that actually increase people's concerns? Vibhav.
Well, my view is that, in fact, there are plenty of things that people can always do from a behavior and lifestyle perspective, even as we track risk, right? You know, even though there is no medication today that changes Alzheimer's disease. But if we can get people engaged in a brain healthy lifestyle, if we can have them try to maximize a brain health score, right? There is plenty of research that shows that you will probably stave off cognitive decline for longer, right? You will probably, at the very least, feel cognitively very fit up until the time you get hit with that disease. And in fact, and I think this is your point, Mia, that the moment we sort of engage in these brain healthy lifestyles, we can also understand where the deficits are. Is it sort of chronic sleep issues? Is it other types of social withdrawal? And we could have interventions, what I call functional prosthetics, right, which sort of help with just those behaviors. And all this, I think, will help. I think in our view, you said this before, right? What about Google-armed patients? I think people will have more and more information about themselves. They will have more and more data. We cannot protect people from information. We cannot protect people from data. Yeah. People will learn more and more about how their different organs are evolving.
I should say that people are giving up sleep apps because they are so anxious about sleeping after having looked at their sleep app that they're not sleeping.
No, true.
Yes.
And this is a bit back for this issue. The risk profiles and interventions may be different. You highlighted like psychosocial factors, stress, sleep, especially for younger persons. So how can we highlight these and make something for this? Physical inactivity, loneliness. There are a lot of, I would say, not new risk factors, but novel risk factors where we could highlight more. And again, risk factors at midlife and later in life may be partly different, or the importance for them is different. It may be different for me and you, so we need to know what is my risk profile.
So come up with a better sleep app would be my response, right? I mean, I'm just partly being flippant, but if somebody has comorbid anxiety disorder, maybe the way you address sleep in them is very different from people who don't, right? And this is the customization which data will provide to you. And in fact, we will go towards a paradigm where your own data will tell us what kind of intervention is best suited for you.
Kim.
Yeah, and I think it raises a very good point that if we have the ability to detect different diseases, it also comes with a responsibility to give people something to do about it.
Yeah.
And I do agree that we always have something we can do about it, because things that improve general health will generally impact brain health in a good manner. So even if we can't cure that specific disease, we may be able to improve overall quality of life and overall state of independency and daily functional ability without curing the disease, but we can still give people something very specific to act on. The other thing, the opposite, would be you tell people that they have a disease and you then leave them in the darkness. And that's what happens very often even today in our healthcare system. And I just want to make one point, bring it back to this new models and who's going to pay for it. To give one example, in our little country of Denmark, 20,000 people a year get traumatic brain injury or stroke. A very, very small proportion of those people are actually getting some type of specialized treatment, which is being paid for. So if we only relied on traditional methods and the budget available to pay for that types of treatment, a lot of people would miss out on the fact that the marginal cost of giving a digital therapeutic to one extra person is 0. So we should also make our digital therapeutics available to all those people who would otherwise never have been offered anything in the healthcare system.
Yeah.
And one more thing I would like to add, now we have the lifestyle interventions. In the future, hopefully, we can combine non-pharma and pharma interventions. Then we have the model, is again more tailored interventions, more personalized interventions. I think lifestyle is always there, and then hopefully when we have the model there, we can add the kind of pharma what is there. I don't think there will be one drug for brain disorders. It's more like the cocktail, and that's why both non-pharma and pharma should be there.
Will there ever be a digital solution to the problem of true understanding of what people are eating? I mean, I know people photograph their food all the time. It's a thing. I can't think why. People do photograph their food, but that's been people have always lied about what they're eating. Always. There is always one less biscuit. Alcohol. I drink less than my doctor. That's all you need to know. Yes.
You brought up this question of veracity and variety and volume, right? I think that over the long run, if you want to say that, are you eating brain-healthy food, right? Most people, if they are interested in their brain health, are not that interested in lying about it. You just have to make it convenient from them. What if you just had an app that just scanned your grocery bill every week and told you that, it's buying brain-healthy foods, right? If you're buying it, you're probably eating it. Is that good enough? I would say we should think about those things quite carefully. It may be good enough. It maybe motivates people to change their shopping habits. Before they go to the checkout counter, they can put that app on their phone and it tells you
put that
heart healthy,
down.
brain healthy
Yes.
or not. That's it.
But okay, so let's just stick with the alcohol abuse, because a big cause of mental health problems. So how can you combine molecular phenotyping with the digital phenotyping? Because molecular phenotyping, you can look at, for instance, methylation on DNA as a proxy for alcohol use. So could you combine those things?
I would argue you combine them by combining them. I think we just have to, like I said earlier, collect a lot of data sets where you have genetic, epigenetic, molecular data, gene expression profiling, proteomics data, digital biomarkers, all collected from the same patient as they evolve over time and clinically characterized. These are the kind of data sets that we believe in. These are the data sets that we want to generate, and they give a kind of cross-validity that is absolutely necessary. And it will be a combination of some baseline risk factors you have, that will combine with dynamic factors. Those dynamic factors could be epigenetic, it could be gene expression, blood-based biochemical changes combined with genetic information, digital information. So I think that absolutely has to be the way.
I agree, and I think it's like deeply phenotyped data. It can be both biological and kind of digital, and that's the direction where we are going. As an example, we try to have in the finger all the chivas, omics, inflammation.
Just explain what finger is.
Sorry, the finger was the big trial which I have been conducting, the first randomized control trial, showing that with this finger model, with physical activity, cognitive training, social activities, healthy diet, taking care of
and
all.
This is in dementias.
And it's an intervention, it's a randomized control trial. So that was the model how we could reduce the risk of cognitive impairment and also functional impairment among at-risk persons. So that was a big trial, and now many countries are following that with the worldwide fingers. And we aim to build it in. It would be a unique opportunity to have big data, have intervention data, and have both deeply phenotyped data. How we use that data, how we analyze that, to be honest, I don't know yet. You need to be a maybe data scientist to really do that. And again, that's why we need expertise from I would say, all of you here.
Kim.
I think it also brings up an interesting question about which types of biomarkers do we use in which part of the patient journey. Because very early on, when we're talking at-risk populations or even healthy individuals, then pure digital biomarkers would be excellent because they have a very, very far reach. But once we get closer to the fact that we need to actually do a diagnosis, then we should start combining digital with physiological biomarkers.
I would argue that at any point, combining other information. So for example, right, if you are an offspring of a parent with bipolar disorder, right, at that point of time, fragmentation in certain types of behaviors, sleep fragmentation, right, circadian rhythm imbalances probably mean something very different in you, given this background, than they do in somebody else who does not have that background. And even if you're looking at changes, how much of a change should raise a flag, right, is going to be different for these two individuals. So I do think that at the end of the day, all the digital information will have to be interpreted in context of the genetic, the background, the family history, the clinical history of that individual, and there is probably no getting away from that.
You need to have the baseline, and you need to follow up.
Yeah.
But Margaret, carry on.
Yeah, I just want to say I completely agree insofar as that data is available. And then if we're talking about, let's say, diagnosing Alzheimer's disease, maybe you do need a PET scan at some point, which is not available for that individual person. So if the data is available, by all means, digital biomarkers with data that we have on regular biomarkers.
Margaret, I want to take you back to a central conundrum here, which is about the patient and somebody that actually doesn't think that they are a patient, but that we are thinking them as a potential patient. How do we cope with that?
I think the main thing we need to do is provide information. There's education that can be done. When you're looking specifically at family carers and their risk for example, depression, it's important that they understand that they are at risk, and sometimes they don't see this. And we also need to look at parity of esteem as well. You know, when we look at physical health and mental health, we need to discuss that we should have equal opportunities for both. We often get comorbidities, and that's something that is not often discussed. For example, in family carers, they're often looking after their children who are unwell. But they're also looking after a parent, perhaps, with a degenerative condition like Alzheimer's disease. So I think these are all things that we need to take into account. And just awareness raising in general. And for something like that, patient groups or family carer associations are a great way of doing this, of sort of helping disseminate the information, helping make sure Dr. Google doesn't work overtime, and that people actually understand their condition, what their risk factors might be for other conditions as well. Okay.
Any thoughts from you, Peter?
Well, actually, I wanted to bring up a different point, if I may. That is where we've talked a lot about digital biomarkers and how we would use them, but I think sometimes we're losing track of the fact that the devices we use to generate that data were never developed for that purpose. They were developed to entertain us, to inform us. And of course, you could argue that it makes a lot of sense that the devices that we perform our social interactions on are a good way to collect relevant data. But I think we should also ask a question, maybe a provocative question. I mean, what is the type of sensor, the type of detector that is not there yet, and that for brain health is really essential? That's a part of the discussion I've really missed. How do we get to sensitive, highly specific diagnosis using devices we own? What is the missing? What are additional technologies we might want to add to make that more precise?
That's a really interesting question. And is that one that you think that IMI should think about? You know, what are the additional technologies that we need? I mean, we can look at movement, we can look at speech detection, we can look at all those kind of things. But is there something else that we're currently missing?
Exactly. Yeah. I mean, so today we are able to look at a black hole 55 million light years away, but we don't have technology to look into the brain. Look 10 centimeters deep and look at a neuron. Actually, if you think about it, it's just the wrong way of going about it. So what are the pieces of tech that would really make a difference in terms of looking at the brain, looking at brain health in a continuous way, using the devices we own, either devices we wear or devices that are just all around us?
I mean, I don't know whether this is a possibility or not, but you know, we're beginning to use artificial intelligence to look at retinal scans. You know, when you look at a retinal scan, you're kind of looking at the brain. So, you know, is there a way that we look at our phones? I'm now making this up. Is there a way that we look at our phones? Because I'm sure that once we've started to use AI on retinal scans in huge volume, I suspect we're going to start to get some information out about how, you know, functions of brain.
Yeah, there is plenty of efforts looking at retinal scans for detecting Alzheimer's, and we are involved in some of them. But I do want to make the general point that we have to work very hard to reuse the data that are already being generated by existing devices like your smartphone, smart refrigerator, smart car, wearable that you have, to derive medical insight from this data that's useful for the patient and the physician and that relationship. On the other hand, simultaneously, we have to think about what new types of specific sensors could we develop, right? And in a way that's translatable, that can reach a lot of people. And I think they both will have to go hand in hand. But it's all about the art of the possible and the urgency of now. I think that we have to already start thinking about what can we do with the data streams that are already being generated while thinking about the next generation of sensors.
And you have to learn how to, take out the things which you might be confused by. I mean, how many of you have been furious because your teenagers are behaving badly? And imagine your driving is very erratic after you've had yet another row with your son about cleaning his bedroom. Is that a marker of problems with your brain health, or is it just simply an argument with your teenager?
Well, I think this is, your driving performance, a lot of people are interested in it, right? And you may not want to transmit your driving performance to everybody, but driving a car is cognitively very demanding. It integrates a lot of cognitive domains. And in fact, your car is one giant sensor with a lot of gadgetry. If you wanted, you could subscribe yourself to your own service provided by your own car that will, over years, track cognitive and functional decline in a way that you might find meaningful, that goes away from all the noise that I was, tired that night and, had a few too many drinks. You're talking about longitudinal data collected over a long period of time. And how do we develop a biomarker of cognition and function from all the data that comes from your car? This is something that work that still needs to be done, but it can be and will be done. In fact, even today, people know this, FDA requires simulation. Driving simulation is one of the very accepted tests to show that your drug is not creating any sensitive cognitive impairment, right? We know this. It's done in these limited settings. We could translate this into a solution that's used by everybody in ways that will be helpful, but work needs to be done to develop these digital biomarkers.
Okay, so I'm going to ask all of you now. I said that we would do this, that we would come to the end of each session, and we're coming to the close of this one, and say, what is it that you think IMI ought to be doing? Something that only a public-private partnership like IMI could achieve. Okay. Do you want to start, Peter?
I'll start. So I think,
just very briefly.
Yes. So I think integration of data is, of course, extremely important. There is a lot of data available already. Let's make sure we make use of it. So we have to enable that, and that I think can only be done in a public-private partnership. But then the other thing, and this may be my thing, is that let's also work on building the tech. I'm a tech guy, so I've got my tech hat on, but let's also work on building the tech that is geared towards brain health. Let's measure that thing in our head. It's so close by, and yet we know so little about it. So
okay.
I think, as I mentioned, that we need, of course, much more studies to really have the evidence base. So having interventions, randomized controlled trials, that's still the gold standard. And what IMI can do is really put together scientists, public, private, different stakeholders to build it in. For example, adding digital biomarkers for the new studies or planned studies that are there, having the regulatory aspects, which I mentioned, to start with, that we are sitting there, all of us, and doing this. So that I would think
that's
is
a strong
needed.
message that's come out, inclusion of digital biomarkers. Viva.
Yeah, I would say that if we wanted to create a single cholesterol-like number, create and popularize, which is essentially your brain health score, right? How would we do it? This number cannot be owned by any single entity, right? We have to think about collectively saying, what do we today agree is important for brain health? Good sleep, good social engagement, low stress, high levels of physical activity. All this can be measured today. How do we bring it together, create a number, and then over time create validity around that number that it improves outcomes? That's longer term. But can we today create a number that people can track that has, credibility behind it, that does no harm, that only does good, and it has to be device agnostic. I can measure my social engagement, physical activity, sleep, or stress levels using whatever ecosystem of sensors I have available, but we have an algorithm that calculates a number that you can engage with, that you can modify, that can be used to drive interventions. We can tell what component is causing a lower brain health score. Is it sleep? Is it stress? Is it lack of physical activity? Whatever.
Okay.
So anyway, so I'll stop there, but I do think that IMI projects become successful when they latch onto something important and big
so we're
like
going to
that.
call it the VN or the VBAV number. Kim.
So two suggestions, one specific to brain health and one more to digital health. The first one would be to say this panel is actually about detection and prevention. How do we move the entire ecosystem into detection and prevention, and what are specific brain health related groups at risk, for example, for mental disorders or neurodegenerative disease, that we could possibly target with digital solutions, and what would those digital solutions be? That could be one particular project. Another one would be this: how do we cut a path through the jungle? How do we pave the way? How do we put the signposts so we can get all the digital solutions through in the right way, with the right evidence, through the right regulatory processes, all the way to potential reimbursement across on a European level. So we have that clear pathway done, because that is probably what is missing the most right now in Europe, I think. And if the big pharma companies, for example, they want good digital solutions to build their portfolios, I mean, they need to invest, even though it could potentially cannibalize treatments later on, etc. The public health sector needs to invest in making that pathway clear.
Okay, Margaret, big problem. It's for the public, that we're talking about. It's not for patients, really. And that's our traditional model, isn't it? We think of patients and we think of patient inclusion, but actually here is something where public engagement is going to be critical to the future.
Yes, and I think it's extremely important for us all to remember that one day we will all be patients at some point in our lives.
Thank you for that cheery note.
Sorry. But I think one of the things that IMI could do is perhaps to continue to support some of the projects which have already shown success, but also add that component of lifestyle and prevention, which is so important for families, especially when affected by conditions such as Alzheimer's, which cause so much fear for families in which multiple generations have been affected. So I guess that from our perspective would be what we would consider to be important. And obviously the acceptance that digital is here to stay, and that families and patients can help spread the message of how useful and how important that is.
Okay.
So I'm not a scientist, I'll take a different tack.
Yeah, the regulator of it.
Yeah, I think that IMI can do a few things. One of the most important things I think they can do is provide maybe a best practices or guidelines, kind of making very clear what we can do to either pre-certify data sets, help partners to understand in a very clear manner with a roadmap, with even pictures if that's necessary, what we can do to be GDPR compliant, and how to get past those regulatory hurdles as fast as possible. And the other thing, I think, is just advocating for, as much as possible, having a coordinated regulatory system across Europe, because the more that national laws differ, the more difficult it's going to be for research institutions to comply.
Okay, thank you very much. And I was also hearing from you that developing new business models for this is actually also critical, because we can't do things in the same way that we've done before. Okay, well, thank you very much, panel. Thank you to all of those who were submitting questions. We're going to have a break now, so fortify yourself with coffee and croissant, because we've got the next session coming up very shortly. And when we ask you to come back in, can you come back in promptly? Thank you so much.